old is the patient?
2 years.
2 years. So this is the ideal age. Still, he is within the, I would say, the best age limit for the implantation.
Other OT.
So, if we talk about cochlear implantation, this has revolutionized the hearing rehabilitation of the profoundly deaf patients.
Yes, yes.
You know, when this science of cochlear implant started, the indications were very limited for profoundly deaf children having the pure tone more than threshold more than 85 degree and the word recognition score of some limitation 20-30% kind of a thing. But once this got popularized and taken up by many people, more and more cases done, the anatomy and the radiology improved the understanding, the applications expanded like anything. Now there is no limit as far as criteria are concerned, no limit of hearing threshold or anything. Anybody, maybe a child or adult, elderly, even 90 years old, anybody having hearing loss which is not benefited, sensorineural hearing loss not benefited by hearing aid, is the candidate for cochlear implant. By and large, as simple as that.
We have MRI and CT scan, and
Yes.
I think we have people want to see all the structures on
Okay.
MRI and CT scan,
Sure,
irrelevant of CT scan with CI also.
Sure,
And
boss.
Dr. Satish, we have our one more legend, Dr. SP Dubey was.
Yeah. He is here?
Yeah, he is here right now.
Oh, Dubey Saab, welcome.
So he is all
Welcome,
the
sir.
from
I am
Hyderabad.
enjoying your surgery since yesterday
Arey boss.
on
So
my
nice of
mobile.
you.
On
Now I am
mobile.
here.
Always nice to see you.
Was come forward. Dr.
Dubey Saab
Dubey
is very close to our heart and he is such a wonderful person.
Dr. Dubey is the mentor of many ENTs, including me.
And now he has a vast experience of cochlear implant surgery,
Very,
done
yeah.
more than 400 cases, and in a very short span of time, he has accomplished these number of cases.
Dr. Haldipur, Dr. Sanjay Agrawala, and Dr. Arshad also there.
Oh,
Haldipur
the whole
size.
team.
Full team is there.
Welcome, welcome Arshad, welcome Sanjay Agrawal sir. So we have all our immediate past president of AOI, the present president of AOI, all are here. We are so honored to have them. Yeah, there is a president-elect. We are honored to have them, and they are really very close to us. They have always guided us, helped us, and I learned so many things from them. They are really doing amazing work, and they are very, very academically oriented people. Thank you so much for being here, sir. So, coming to the cochlear implant again, Dubey Saab, please point out anything you want to express. You are so experienced in this field. Please contribute by whatever way. So, this cochlear implantation indications, as I told, are expanded. So now any patient with sensorineural hearing loss not benefited by means of hearing aid is a candidate for cochlear implant. And once it comes to cochlear implantation, there is a lot of things to be looked into before implantation. Audiological, there are audiological factors need to be looked into, the psychological factor, family counseling, then the imaging aspect. Imaging again has revolutionized the cochlear implantation in the difficult patient. Now the cochlear implantation can be done in the most difficult situation, like Senaroglu described, classified the variety of malformation, and that's very, very practical. So imaging is one aspect which has really revolutionized the science of cochlear implantation, and we need to look into this aspect. We should be able to analyze the CT and MRIs on our own rather than being dependent on the radiologist. Radiologists are good at imaging in the head, neck, in the brain and other regions, but they are not focused into this field of temporal bone and PNS. So we should be able to read ourselves all this CT scan, and we should ask for the proper images which can give us the best details for particular region. So once it comes to ordering and imaging, we should order 0.5 millimeter multiplanar section, not only in the axial, coronal and sagittal, but the double oblique coronal and the oblique sagittal is very, very important, which gives us information of certain areas in details. So the axials are more important. So I will take you through. We have axial section. Do we have coronal? I will take you through the relevant imaging findings to the cochlear implantation. See, yesterday we saw the CT scan from different point of view for a different patient. That was a malformed stapes. Here, this is from the different perspective, cochlear implantation, and CT and MRI both are important. CT will give you the bony details, the details of the cochlea, vestibules, and what CT can give you, it saves you, it gives you the anatomical details, it tells you the difficulty one can come across during the surgery. So it prepares you to handle those situations. MRI will give you other details like the inner ear details, how the fluid is there in the inner ear, the nerves in the intra-auditory meatus, and the abnormalities if there are any in the brain which can complicate the situation. So both are equally important and supplementing each other about the information. So coming to the CT scan, is there Dr. Man Prakash Sharma in the auditorium?
Not yet come.
Sir has come from Jaipur. He has been my teacher. So let me know when he comes. Savas. So coming to the axial CT scan, what do we need to see in cochlear implant? See, if we go from above, in implant we need to see the normal anatomy, any abnormal anatomy or any malformation. See, malformations are not uncommon, particularly in children. This is a prelingual child, needs implantation, 2-year-old. So there could be malformations which can be appreciated on imaging. Those are 20%. Out of malformation, those are 20%. There are certain, I would say, the membranous labyrinth malformation or malformations at the molecular level which you can't appreciate on imaging. And in such children where the congenital hearing loss is there, the incidence of malformation is not uncommon. Up to 20 to 40% children can have some sort of malformation in the inner ear. Means in the labyrinth, maybe cochlea, semicircular canals or the vestibule, and anything can have an impact on the ultimate outcome. So let's see how to read this from this perspective. We are going from above downwards, and the first structure, like we saw yesterday, what you see from above? First structure here at the petrous bone, on the height of the petrous bone. See, the highest structure of the petrous bone is arcuate eminence. That belongs to semicircular canal. If you see the skull have the skull in hand, and if you see from superior inferiorly the petrous bone, the highest structures come is the superior semicircular canal. Can you see this?
Yes.
So that's the superior semicircular canal. Anteriorly, we saw yesterday the semicircular canals. We'll see today as well in the glomus and the acoustic case when we drill out. The anterior end is a ampullary end and the posterior is a non-ampullary end. Can you see here as you go down? That's the ampullary end, that's the non-ampullary end, and what you see here is the petrous apex. Now, if you follow that down, this is the ampullary, non-ampullary end, ampullary, non-ampullary end, and see this non-ampullary end is continuing behind on the posterior aspect of the petrous bone. Can you appreciate?
Yes.
That is going to join the non-ampullary end of the posterior canal to form the common crus. I will show today how the common crus is formed. Then, what is coming as you go down below the arcuate eminence is now, see this for the audience, like I told yesterday, how these sections are planned. From above downwards, in which plane? Arvind, tuya again. See this? Like you take this to understand easily from this perspective, like you are operating on a patient is lying in this position, and these sections are planned from above downwards in this axial plane. in this axial plane. So above downwards we'll appreciate what structures are coming. So after the semicircular canal, see the beginning of the intra-aortic meatus now. Can you see this? Hello?
Yes, yes.
This is very important in cochlear implantation to see the dimensions of the length and breadth of the intra-aortic meatus, which is important. If the intra-aortic meatus is too narrow, less than 2.5 millimeter, the chances of cochlear nerve deficiencies are high. It has been correlated. So one should be suspicious. If it's too dilated, bulbous, then the chances of communication to the inner ear and the resultant perilimb gusher are high. Okay? So the dimensions are important, and our own Dr. Manoj Manikot has described, published a study in assessing the degree of difficulty of cochlear implantation in identifying the orientation of the cochlea. One of the factors is the angle of the both intra-aortic meatus, how they are angled to each other. I'll show in the cornal section, and that is one of the factor by means of which you can have a gross idea that the cochlea may be rotated. So in the intra-aortic meatus, now we are going from above downwards. Here we already see the superior semicircular canal, and here it is opening into the vestibule. That's the beginning of the upper part of the vestibule. And see here, the two groups of nerves are going from the intra-aortic meatus. If you appreciate it clearly, how the picture there?
Yeah, yeah.
See the anterior nerve which is going anteriorly. What is that? Facial nerve. See in the intra-aortic meatus, the four nerves are arranged in a particular order. The superior group of nerves are superior vestibular posteriorly and the facial nerve anteriorly, and they are separated by a bridge of bone. Can you see this bridge of bone?
Yes.
And this is the posterior nerve. So this bridge of bone is Bill's bar. We'll see today in the translab situation. You see in the next section, it's so clear. So that's the Bill's bar, that's the labyrinthine segment of the facial nerve emerging from here anteriorly, and posteriorly is the nerve to the superior ampullary nerve, is a part of superior vestibular nerve going to the semicircular canal, to the vestibule. Okay? Now, as you go down, see the facial nerve very clear, and it is broadening here to form the genu. That's the anterior genu of the facial nerve. In a good high resolution, you can see from here anteriorly emanating the another nerve, that is GSPN. Sometimes you are fortunate and you can find the GSPN very clear here. Now here it comes to the genu, and then it goes backwards, forming the tympanic segment. Can you see the beginning of the tympanic segment?
Yes, yes.
Now see, what is this? This is lateral semicircular canal coming into picture. See, I showed you how you take the section coming from below, above downwards. So at this level, what you see? The dome of the lateral semicircular canal. This is the ampullary end, this is the non-ampullary end. It is like this. This is ampullary end, this is non-ampullary end, and these are opening in the vestibule. See how big the opening, how big the vestibule is normally. Yesterday we saw the foot plate which was coming on the vestibule from lateral side. From lateral side here, I will show here. So this big vestibule, it is partly covered laterally by the foot plate, and rest of the vestibule is covered by the tympanic segment of the facial nerve and the genu. So this is the vestibule you can see. So in the cochlear implantation, you need to look at this level. If your facial nerve is malformed, sometimes in the deformities like IP1 or common cavity, the facial nerve can be deformed. Sometimes it goes more anterior to the cochlea, and sometimes when the cochlear agenesis, the vestibule, the course of the facial nerve is malformed. So we need to see in the cochlear implant cases the course of the facial nerve completely. And vestibule, its normal size vestibule, sometimes it is dilated. Dilated vestibule is one of the commonest abnormality. Abnormal lateral semicircular canal, I believe, is the commonest malformation, inner ear malformation, and enlarged vestibule is after that. So this malformation, we should look into this aspect, because if the vestibule is enlarged and the endolymphatic duct is enlarged, we can suspect some sort of perilymph ooze or egress of the more perilymph in that particular situation when you open the cochlea. So we should be prepared of that. Now, can you see one structure at the posterior aspect of the petrous bone here?
Yes, it's aqueduct.
That is communicated to the vestibule. It is a J-shaped duct. I will show in the translab case the details of this anatomy. So this is the vestibular aqueduct. This is an endolymphatic duct. Cochlear aqueduct is a perilymphatic duct. So this emerges from the medial wall of the vestibule as a tiny opening where you can barely pass a hair. So tiny opening, then the duct goes posteriorly underneath the common crus and then take a inferior course along the posterior aspect of the petrous bone to open in the endolymphatic sac, which is a double dural wall structure here at the posterior edge of the petrous bone. So we need to see this structure in the cochlear implant scenario. I am just showing the CT scan from the cochlear implant perspective. If the vestibular aqueduct is enlarged, that is something to be kept in mind, and this is part of one of the anomaly, the triad of Mondini's triad, in which the vestibular aqueduct is enlarged along with the vestibule and the malformation of the cochlea, that is IP2. So how you can assess the enlargement of the aqueduct? This is the operculum where it opens at the posterior surface, that's the beginning, and in the middle of the course, if it is enlarged by more than 1.5 millimeter, it can be considered as an enlarged vestibular aqueduct. There are many more ways to find it by means of measuring the angle along the petrous bone and then define a line like this, but by and large more than 1.5 millimeter in the middle of the course. If it is more than that, it is termed enlarged. Now, as you go below, now you see in the atic, you see the atic, if you go see in the next pictures, the malleus head and the incus coming up as an ice cream cone appearance. And see, here in the next section now, the tympanic segment of the facial now coming. Can you see this?
Yeah, very clearly.
This, we are just following this labyrinthine segment, then the genu, and then the tympanic segment. As you come down from the genu, the tympanic segment is coming obliquely, and this runs in the wall in the floor of the atic. See, this is lateral, this is medial, this is atic where the ossicles are there. Okay, this is anterior, this is posterior, this is lateral, this is medial. And here in the floor of the atic, how the tympanic segment is running and the relationship with the lateral semicircular canal and the vestibule. See here, what is there medial to the facial now? This is lateral, this is medial. What is there medial to the facial now? Vestibule.
Vestibule.
We discussed yesterday in the atretic case, the oval window atresia, if the facial now comes down over the oval window, just underneath is the vestibule, and you have to do plan some sort of vestibulotomy, either superior or inferior in that situation. But wherever you go, the medial structure is vestibule. Okay, so that's the lateral canal, that's the vestibule, and now anteriorly what is appearing? What is appearing here? Can you see? This is the vestibule, this is the part of the interauditory meatus inferiorly, and this is cochlea. Can you see this? Now, the important, which is more in respect to the cochlear implant, more relevant, is the anatomy of the cochlea now. So, what you see the first appearance of the cochlea, which turn of the cochlea is this?
Basal.
Basal turn. The last appearance, when you go down, again will be basal turn. So, basal turn is the biggest one, like I will draw here. Basal turn goes like this. The biggest one. The rest of the two turns are within the periphery of the basal turn. So, basal turn is the biggest one, and right from the beginning, the first appearance of the cochlea, what you see is the basal turn. Now, as you go down, some important anatomy drastically changing in this particular section is what you see, the tympanic segment of the facial now going there and going to the here posteriorly where it is forming the genu. Can you see this?
Yes, yes.
Very clear. Now, and see here is the vestibule below, the lower part of the lateral canal. That's the posterior canal, which is the non-ampullary end of the posterior and the superior canal, forming the common crus here posteriorly, and this is the last part of the intra-auditory canal, the inferior part, and what it is giving there to the cochlea, that is the cochlear nerve which is forming here in the cochlea and going to the intra-auditory meatus. So this particular space is known as cochlear aperture. Can you see this?
Yes, yes.
The size of the cochlear aperture assessment is very important in cochlear implant case. See how much detail a CT scan can give. If the normal cochlear aperture is 1.8 mm by and large. If this is less than 1.4, it can be considered that there is a possibility of cochlear nerve hypoplasia, and you have to be careful. You need to do a lot of other tests and counseling to the patient that he may or may not benefit with a cochlear implant and may have to go with the ABI further. So this is the cochlear aperture. We need to see in every case the size of the cochlear aperture as you see on the CT scan. Now as you go down, now see, follow the facial nerve here. What we see, this is the tympanic segment of the facial nerve forming the genu. What is going to come below the tympanic segment now? In the next section, what should be there? What is there below the tympanic segment?
Oval window.
Oval window. So now let's go down. See the glimpse of the stapedial arch. We'll see in the next case the step is very well placed on the oval window. Can you see?
Yeah.
The anterior and the posterior crest of the stapes, the handle of the malleus here, which is broadened and tapering down as you go, as you see in the next cases, maybe the neck of the malleus, and this is the long process of the incus. Can you see?
Yes, yes.
So here the facial nerve was coming to the genu. That's the second genu of the facial nerve. That's the cochlear aperture. And as you go, as you see further, see the posterior semicircular canal. As you go down further, this is the stapedial arch. See, very clear. Now this is what? This is what anteriorly, anterior to that, the process is cochlear formation. What is there immediately below the horizontal segment of the facial nerve, anterior to oval window, is the processus cochleariformis, which is transmitting the tendon of tensa tympani. So here is the processus cochleariformis, the neck of the malleus, long process of the incus, stapedial arch, that's the vestibule, and this is the ampullary end of the, as you come inferiorly here, the ampullary end of the posterior canal opening into the vestibule. Can you see? And this air space behind the foot plate, what is that? I mentioned yesterday, the posterior tympanic sinus. You remember?
Yes, you mentioned.
That's the posterior tympanic sinus behind the stapes. Below the level of the stapes will be the sinus tympani proper. And now see here the full-blown mid-modular picture of the cochlea. Can you see? Hello?
Yes, yes.
What is this hyperdensity here inside the cochlear aperture?
Modulus.
That is modulus. These are the basal ton in the cut section, middle ton, apical ton, maybe here you can't see. But this is how you can see. This is the proper mid-modular view of the cochlea at this level. You see the modulus and all the turns of the cochlea. Now, see, you saw the stapedial tendon, and what is this? Muscle going anteriorly.
Tensor tympani.
Tensor tympani. See in the next section, the tensor tympani going anteriorly. Okay? And just what is going to come just below the tensor tympani?
Eustachian.
See in the next few sections the eustachian tube, the air containing space. Can you see? That's how you can easily correlate the CT scan. Assume you are seeing the scan in the same situation in which, same position in which you operate. Like same way, the coronal scans in the PNS, you get the information in the same plane in which you operate and easier to understand. Similarly, for the otology, the axial sections are so easy to understand if you think in your mind that you are looking in the same plane in which you operate. So, now here, the next picture inferiorly, this is sinus tympani. Can you see?
Yes.
What is there lateral to sinus tympani? This is facial nerve. We left the facial nerve here at the genu. Now we have to follow this in the axial section. It will be cut in a dot-like structure, circular structure, and that's the mastoid segment or the vertical segment of the facial nerve. Okay? That's the
we've lost the voice.
Hello?
Yeah, we've got you back, yeah.
Okay. You can hear me back?
Yeah, you were on the facial nerve when we lost the voice.
Okay. So this was the mastoid segment of the facial nerve, vertical segment. Medial to that is sinus tympani, the remnant of the stapedial arch. We saw the full-blown picture in the previous section. And there's the tensor tympani going anteriorly. There's the posterior semicircular canal. And now we are going to leave the labyrinth above in the next section, because this is the last part of the labyrinth coming into the picture. Okay? As you go down, the labyrinth disappears, and this is the cochlea. Here you can see in the next picture all the three scala. Can you see? If you see closely, this is the basal tongue. Can you see?
Yes.
The middle tongue and the apical tongue, and you even appreciate the interscalar septum. Can you see this?
Yeah, if you can zoom
If
in a
you
little
focus,
more.
zoom in here. See the interscalar septum.
Yeah, we can see that.
This is very important to appreciate on CT scan. You can appreciate on a very good 3 Tesla MRI as well. The fluid in the 3 turns with the interscalar septum, which is a hypodense structure on MRI. So this is very important to appreciate, because a lot of malformations have these interscalar septum deficiency, the modular deficiency like Sanar Gaglu described according to the embryogenesis. Quickly in 1 minute you can understand easily. Or in the fetus, the development of the labyrinth begins in the 3rd week of life, and it develops as an otocyst. If the embryogenesis by any region happens to stop in that period, there will be no development of the labyrinth. That will be termed as Michel's deformity. Okay? Hello?
Yeah.
Then as the development progresses in the 4th week, the otocyst enlarges and develops into a common space without any internal architecture of the cochlea. How it develops as a common space. And in that period, in the 4th week, if the development happens to get arrested, what will be the end result deformity? Will be a
Mondini.
common cavity. Got my point? There will be no internal architecture separating the cochlea and vestibule, anything. Will be it differentiates later. So if embryogenesis stops there, then will be find end result as a common cavity deformity. Okay? And in that situation, the separation from the interauditory meatus is not yet happened, and you will find a CSF gusher in those situations. Now when the cochlea further differentiates, the common cavity further differentiates into 5th week into a separate cochlea and vestibule. And what is then that? If the development happens to arrest in that period, there will be a separate cochlea with no internal architecture and communication to the interauditory meatus, and a separate vestibule little enlarged. What is that? Incomplete partition type 1. And again has a propensity to give gusher like common cavity. Then in the 6th week, further differentiation in the internal architecture of the cochlea develops, varying. That is known as cochlear hypoplasia if the arrest happens to occur there. That could be varying amount of, there are 4 types of cochlear hypoplasia. But hypoplasia, by and large, the cochlea is less in size, but is a normal in architecture. On the outside morphology and some internal architecture, maybe less than 1.5 tons, but the overall architecture is there. That is cochlear hypoplasia. Again, the cochlear implant is difficult in that situation, because you need to use a less length of the electrode and all those things. I am not going into detail. So if the development further progress in the 7th week, what happens? if the arrest happens, the cochlea develops internal architecture, the modulus, the interscalar septa between the basal and the other tons, but the interscalar septa between the middle and the apical is deficient. It's not fully developed. So that is incomplete partition 2, and if it is associated with an enlarged vestibule and a vestibular aqueduct, that is known as Mondini. And the next is IP3 like this. So you can understand how the embryogenesis is related and how this is brilliantly classified by Levan Sinaroglu, who happened to be in India in Bangalore last week at Dr. Shankar Medical's place. It was amazing. It's always, you go through his publications, what kind of work he has done. He has spent months and months in the Shuknet lab, the pathology lab, did cochlear sections, did the embryos, study the embryos cochlea, how the embryogenesis happens, and finally came out with a classification that is amazing. Hats off to him. So this is the level of this where you need to see all these structures. Now, coming further, now at this stage, you need to see some other aspect of the dimensions of the cavity. Like here is going to be the round window next. This is the sigmoid sinus going on behind. So how is the space between how the mastoid is spaced? Sometimes there is narrow contracted mastoid which can cause problems to the surgeons. We need to see at this fact how it is pneumatized or not. Now coming down further, what you see in the axial sections. See now, this was the facial now. Can you see here?
Yes.
And what is emerging from the anterior aspect? Anybody?
Chorda.
No. Chorda doesn't emerge from the facial. Here. It emerges lower down in the lower mastoid segment and come up. This is? Yes. That's the stapedius tendon. Can you see? Now at this level, we are following the sinus tympani below. See, follow the sinus tympani below. And what is this? The hypodensity here. This is the basal ton. What is this?
Round window.
Round window. You see in the next section, the round window very, very clear. Now, most important thing, how you can assess the, see in this case, we are going to go by posterior tympanotomy approach. By means of radiology, we can get to know how difficult it is going to approach the round window. Sometimes the cochlea is rotated and it's difficult to access the round window. How you can easily make out by means of CT scan. I refer you to, there are n number of publications in the literature. If you want to go such radiology details, you must refer to a few of the publications published by our own. Dr. Neelam Ved has a very good publication. Manoj Manikot has a very good publication. And see, I tell you the simplest way how to find the accessibility of the round window. There are many, many views, many, many angles one can have been described. I tell you simple. We are coming from here laterally to visualize the round window through the mastoid air cells. Okay? Hello?
Yes.
Now here is the facial now. Okay? Medially. Imagine you are doing a posterior tympanotomy. What is your medial limit? Facial now.
Facial.
What is your lateral limit? Chorda tympani representing annulus. The annulus is our lateral limit as we are not supposed to enter into the extrauterine canal. So can you see the extrauterine canal?
Yes.
That is the level of the chorda tympani. Okay? The annulus at the medial end and the chorda tympani. For details of the chorda tympani, you can see the entire chorda tympani emerging from the facial now, the lower segment, mastoid segment, and then entering into the middle ear, can be best appreciated by the oblique sagittal reconstruction images. We don't have that. In that, you will see the picture like this, the vertical course of the facial now, and the chorda emerging like this to enter into the middle ear. And you can actually see the dimension of the facial recess, how is the width of the facial recess. So that's the oblique sagittal reconstruction images which gives you this beautiful picture and the details. So here is the chorda and here is the facial now. If I draw and see, this is the round window. Can you see here?
Yes.
This is the long axis of the basal ton. As you go down to the last part of the basal ton, I will show you. Here is the round window. So when you implant, you are supposed to come here between your lateral and medial limit in the facial recess. Now here you can measure the dimension of the facial recess by and large. And if you are coming from laterally here, if your round window falls in the middle of this two lines, what does it mean?
Yeah, access will be good.
Yes, you see through the posterior tympanotomy and your round window is accessible. If it is not, presume that you are going to face difficulty, and then you have to have other alternatives in your mind to address that situation. So simply you can address by this means. Then the Manoj has described another line. Draw a line at this level along the sigmoid sinus and then along the canal. If your basal tongue falls in between, by and large, your round window is favorable and visible. And this round window visibility has been classified into three types. When the round window is completely visible, incompletely, and non-visible, and this all depends upon the cochlear rotation. Cochlear rotation, I will tell you on a complete axial picture how the Bills has described the angle, how the cochlea rotates from the child to adult, and where you are when you are operating, how you can pick up the cochlear rotation very well. So this is how you can pick up. Now as you go down, this is your the facial now. This is your what is this? Anybody? This is a tensor tympani tendon. This is your eustachian tube. And what is there medial to eustachian tube?
Carotid.
Carotid artery. See now, we saw yesterday the cochlea and carotid are so intimately related. See the basal tongue of the cochlea, how thick the bone between the basal tongue and the carotid you must assess. Sometimes this bone is deficient, uncommonly, but has been reported, and the surgeon implanting into the basal tongue, and the implant went into cochlear canal, the carotid canal. So you must see how this anatomy is related. This is very important in drill out procedures. Like in ossificans, if you are drilling out the cochlea, you must know the distance from the carotid artery, and you must expose this region thoroughly to prevent injury to the carotid artery. So this is what you need to see in cochlear implant. So we are just seeing the radiology from the cochlear implant perspective, how important is the CT scan. Now, at this picture, the round window level, at the lowest turn of the basal tongue, we don't see any sigmoid sinus coming into the picture or the jugular bulb. That means it's not a high jugular bulb. If the jugular bulb is high, then you have to be prepared to deal with that, or you may have to think to the alternative procedure. It is described high like if it is reaching to the basal tongue, it is termed high. If it is going further above to the level of the posterior canal, it is termed very high. And if it is crossing the intra-auditory meatus, that is damn high. So this is a normal jugular bulb. In this situation we don't see. And as you go down, see the basal tongue disappearing at the lowest level, basal tongue, and this is what now the jugular bulb coming into the picture. Can you see this? Now we are at the hypotympanum level. Can you see this?
Yes, yes.
This was the carotid artery. Carotid artery, that's a vertical segment of the carotid now. That was the genu here. Now the vertical segment, vertical petrous, we'll see in the glomus jugular case today. And that's the jugular bulb. And see, medially, see the communication medial. That's the jugular bulb. That's the bone medial to the jugular bulb. What is that? The jugular tubercle. And this is the jugular bulb pars nervosa anteriorly and the jugular bulb posteriorly. This is pars nervosa, through which all the cranial nerves coming into the anterior part of the jugular bulb. And this is the carotid artery, and this is a thick bone. See this bone, we saw yesterday glomus tympanicum. The thick bone is always intact. If this bone is gone between the carotid and the jugular, and if you have a paraganglioma, it is always a glomus jugular. See the bone is intact between the carotid and the jugular, and that's the bone. And at the junction of this bone, here is a canaliculus through which the Jacobson nerve come up in the hypotympanum, running on the cochlear surface. So this is about the CT scan. What you see, do we have coronal?
Dr. Satish.
Yes, boss.
How important is the cochlear length? Is it really relevant?
I tell you, this is theoretically it is relevant. In a normal situation, it's not so relevant. And I tell you the philosophy behind this. There's a huge misconception among cochlear implant surgeons how length of the cochlea should be implanted. That's how this concept of measuring the cochlear length has come. Okay? The cochlea is normally around 32 to 35 millimeter long, the cochlear duct, the entire cochlear duct. And we are not supposed to implant the entire duct. I clear this misconception today here. See, when the cochlea starts, the basal turn starts and then turning into middle and apical. Around the modulus, the core is the modulus. So along the cochlear duct, the spiral ganglion duct runs. Now, when you see one of my dissections of the cochlea, I will always mention that the cochlea has three partitions: scala tympani, scala media, where the cochlear duct is, harboring the organ of Corti, and then the inferior one is scala tympani, running around the modulus. Now, all the hair cells, the inner hair cells leaving the fiber, that is the spiral ganglion hair cell fiber, they come into the modulus, and from there after the ganglion, the postganglionic fiber run to the cochlear nucleus, and those postganglionic fiber form the cochlear nerve. Got what I am trying to say? Hello?
Yeah, yeah.
So those cochlear nerve fibers running through the osseous spiral lamella into the modulus. The modulus contains here in the margin the spiral ganglion cells in the canal of Rosenthal's. Okay? So from all the basal turn, the middle turn and the apical turn, all fibers converge into the modulus where the spiral ganglion cells are. Fiber from basal turn come horizontally into the modulus. The middle turn come obliquely lower down in the modulus. The modulus is directed anterosuperiorly. And from the apical turn turn completely downwards toward the modulus. So the spiral ganglion cell projection in the modulus is not so high, where the implant is going to stimulate. So when you implant, you are not supposed to implant the entire cochlear duct. It is, if you take in terms of circumference, one circumference 360, you are not supposed to implant more than 450 or so, because that covers the entire spiral ganglion cell population. Got my point?
Yeah.
You ask about the measuring the cochlear duct length. You measure the length, it is 32 millimeter, I tell you. You are not supposed to implant the entire 32 millimeter. Your initial maximum 24 millimeter, if you implant, is going to stimulate the entire spiral ganglion cell population. You are not supposed to push beyond that the narrow cochlear lumen or the upper ascending middle turn and the apical turn. You are going to give more of damage than to give benefit. So in spite of measuring the length, you are not going to get anything changed in your approach. Yes, length, if you measure and know it is normal, it's good for you. And how to measure? That is measured in the double oblique coronal sections. There is a formula. Right from the level of the round window, if you draw a line most anteriorly to the level of the ascending turn close to the carotid artery, right from the round window across the modulus, you draw a line. Measure this line on CT scan and there is a formula. Like suppose this line is 9 millimeter. Multiply to 4.16 and whatever comes, like 34, 36, 7 centimeter, whatever, then deduct from that 3.98. That is the formula proposed to know the, by and large, the cochlear duct length. Okay, so normally you don't need to do all this. This is more of theoretical and it's not so important. We need to understand the philosophy. You don't need to implant the entire cochlea. That's it. So this is all about the axial section. In coronal you get some information, like I'll tell you quickly to save the time here now. See in the coronal, what you see the sections anterior to posterior or posterior to anterior. Now, coming from anterior to posterior, see in the labyrinth, what is the most anterior structure? Cochlea. Then is the vestibule in the middle, and then the semicircular canals opening in the vestibule. See the, coming from anterior to posterior, what is this? See the most anterior, TM joint. That's how you can orient yourself. Then coming behind the TM joint, then you come the most anterior structure as cochlea. Can you see this? Just before the cochlea, what was there? Anybody? Carotid. Can you see this? Anterior to cochlea. Then comes the cochlea, and this is the two turns a spiral of the cochlea. That's the full blown picture of the cochlea. See the spiral, and that's the interscalar septa. Okay? Now, what is there? What is below the cochlea? Hypotympanum. You know? Below the cochlea should be hypotympanum, and if there is any high jugular bulb, we can make out best on this picture. Below the cochlea, how high the jugular bulb is, if it is reaching up to the cochlea, if it is going above the level of the cochlea, if it is going above the level of the, going to the floor of the semicircular, the intra-auditory meatus, going above the level of the intra-auditory meatus, like that. Okay? Is that clear?
Yes.
Now you go behind. That's the intra-auditory meatus, that is the vestibule, and those are the three canals. This is lateral canal. This is posterior canal, this is superior canal. This is the best view, and you can, if you have a good oblique coronal image, then that is the ultimate view to find if there is any superior canal dehiscence. That's another pathology. The third window phenomena it creates and give conductive hearing loss. The superior semicircular canal dehiscence you can make out on this CT scan. So now at this level of the vestibule, this is the intra-auditory meatus. This is giving superior and inferior vestibular nerves. Okay? Hello?
Yes, clear.
Yes. So as you go further behind, you see the semicircular canal, the intra-auditory meatus, you again see the dimensions of it, how it is, and inferiorly relationship to the jugular bulb, superiorly to the carotid artery. And if you have a contracted mastoid, how you can define? In any case, like you are operating on a cholesteatoma, you can make out very well on CT scan by measuring the superior inferior distance, how contracted the mastoid is. And simply, this is the tegmen. Can you see? That's the tegmen level.
Yes.
That's the lateral canal level, lateral seminal. Measure the difference between the tegmen and the lateral canal. If it is contracted, the distance will be very less. And that's a decision-making factor in choosing the approach for cholesteatoma. And here in cochlear implant, you can have a fairly good idea that you have a good mastoid to access. Okay? Then, if you see at this level, if you see the lateral canal, what is related to the lateral canal anteromedially? This is the lateral canal. What is there anteromedially here? See this dot? Facial nerve. Can you see this facial nerve? Hello?
Yes.
That's the facial nerve, and immediately here behind is the, below is the oval window. This is above, this is below. The facial nerve and below is the oval window. We have a case today, probably having a facial nerve prolapse of the oval window with a conductive loss. Then you will find the facial nerve here right on the oval window. See that? So you can make out very well on the coronal scan how the facial nerve and oval window are related to each other. So let's move on, and just quickly a few words about the MRI. What you need to see on MRI in a cochlear implant patient. See, these are below upwards picture. Sardesai sir is there. He asked specifically about more emphasis on the MRI. Sardesai sir, this is dedicated to you. So, what you want to see on MRI, three things for cochlear implant perspective. One is whether there is a fluid filled cochlea, where you can see on T2 weighted images. This is T1 weighted. I told you yesterday how you see the T1 and T2 weighted images.
Yes.
On T1, the ventricles are dark. On T2, they are bright. See, the wherever is the fluid will be bright. See the lens in the eye, bright, bright. See the cisterns in the brain, all bright. And on T2, these are dark. Now, on T2, if there is a fluid in the cochlea, it will appear as bright.
Right.
Can you see the cochlear turns here on both sides?
Zoom in. Okay.
Can you
Now
see
it's-
this?
Now it's okay.
Can
Yeah,
you see at this
yeah,
level?
Yes.
There is a fluid filled cochlea with a hypodense modulus. Can you see?
Yes.
And you see the cranial nerves very clear. You need two cuts for the cranial nerve. On the axial, you can see if you have a good fine sections, 1 millimeter section, you can make out the cochlear nerve and the facial nerve, the superior vestibular, inferior vestibular. The best is along the perpendicular to the intra-auditory meatus. Like this is intra-auditory meatus going. If I take a perpendicular cut, we'll find the 4 nerves, and here in implant you must see if there is any cochlear nerve deficiency. So how you can presume, if the cochlear nerve is less than the dimension to any other nerve, it is deficient. It is otherwise a bigger nerve. If it is less in the dimension to the facial nerve, it must be deficient. So like that. And here you can see these hypodense nerves running through the fluid in the intra-auditory meatus very well. This is going to the cochlea, this is going to the vestibule, the cochlear. The MRI is not very clear. And what you see other structures here, see the lateral semicircular canal, the vestibule like you saw on CT scan,
Yes.
and the cochlea anteriorly behind this dot. This is the posterior canal you can see, and here this dot looks like the endolymphatic sac and the duct. So you can make out very well if there is endolymphatic duct or sac dilated, vestibule dilated, cochlea is full of fluid or not. And the third thing you need to see if there is any intracranial pathology above which can impact your implant. So the fluid in the cochlea, the intact nerves, and the intracranial pathology. There are 3 things you need to see by and large on MRI. Rest you can have full details from CT scan. Anything about the radiology?
Anything, sir? Dr. Sardesai, sir.
Sardesai, sir?
Thank you very much, sir. I would be very grateful if you would make a reference to MRIs during
Yes.
PNS also.
Okay, sir, 2 minutes for you.
Sure.
Because you asked and we don't have time to read the MRI more and more. See, it's simple to read the MRI. What you need to know, what you see on T2, what you see in T1 is different. How the structures appear on T1. Like air anywhere, for example. See this, air anywhere will be dark. Maybe T1 or T2. Fat anywhere. Anywhere is the fat will be bright. T1 or T2. Now, suppose you are having a lesion in the clivus, where the marrow containing space which is bright normally, and you have a tumor going to the clivus. What you do is it's difficult to appreciate because of the fat brightness. So you can order a fat suppress images. Then what you see is the tumor only. So MRI has to be very something you need to order according to the patient. What kind of sequences you want. There are n number of sequences for MRI, and this MRI is revolutionized the imaging. CT is only informative for the bony detail, that's it. The most important imaging investigation for the skull base or for anything is MRI. So on MRI you can make out each and everything, what it is, how it is appearing. For every pathology you can have the distinct MRI appearance, and you can make out very well. All these spaces in this region, like this is most complex region, and there is always a confusion. What is masticator space, what is infratemporal fossa, what is parapharyngeal space, what is parotid space, and all this you can make out on MRI. MRI will give you full picture of everything. In any of the parotid case or anything, I will show you in detail what is masticator space, what is infratemporal fossa. These are all different spaces, very well defined. And the best article if you want to refer to is Dr. Suprita from Tata Memorial. She is a radiologist there, amazing radiologist, and she and Dr. Anil D'Cruz published an article in the New England Journal of Medicine. That is something I would say it was a mind-blowing, clearing the concept in this region. There is always a confusion everywhere you go. What is infratemporal fossa, what is masticator space? Somebody will tell different, somebody will say same. From the oncology perspective, it is very important. That's what they publish, and this is crystal clear they have made. And I will show in one of the MRI in the parotid in detail what is these spaces. Oh, there is a question from Mrs. Vadera here in the OT. What is the importance of the 3 Tesla MRI or 1.5 Tesla? This is very important coming from a person involved in the cochlear implant science. Post implantation, you know, the MRI is difficult because you can displace the magnet. Though now the new generation MRIs you can do with a 1.5 Tesla with proper precautions like a tight head bandage or put a plastic card in between that can really help you without affecting the implant. But yes, 3 Tesla MRI gives amazing resolution and details. If I have a 3 Tesla MRI, good picture, I can show you the entire intracochlear details. The interscalar septum, modulus, the scala vestibuli, scala tympani of all the tongues can be clearly, distinctly seen on MRI if you have a 3 Tesla MRI. And in the afternoon, I'll introduce you to our radiologist on the online. How our radiologist, Dr. Mitesh, has a wonderful setup, 3 Tesla MRI, 128 slice CT scan. Amazing details they give on this. We have hours and hours of discussion with him very frequently. So, and the 3 Tesla MRI is the choice of imaging now, if you ask me. 1.5 Tesla, nowadays, I don't see what is there. It's difficult to appreciate the structure once you see the 3 Tesla. Like if you drive Mercedes, it's difficult to drive Maruti sometimes. It's the same feeling. So you, even if you have a 1.5 Tesla MRI, you don't see really what it is there. 3 Tesla is amazing.